Thank you, everyone. Welcome to this auspicious occasion for Sarah's seminar, plus a number of other activities that we have this afternoon as well. So welcome, everyone. I'd like to start by acknowledging the traditional owners of the unceded lands on which the University of Sydney stands, the Gadigal people of the Eora Nation, and pay respects to the knowledge embedded forever in the Aboriginal custodianship of our country. We pay respects to elders past, present, and extend that respect to all Aboriginal and Torres Strait Islander people joining us today. So in a moment, I'll hand over to Dr. Sarah Neville from the Independent Health and Aged Care Pricing Authority. Sarah is going to be talking to us this afternoon, and her seminar is going to reflect on her experiences as a recent Harkness Fellow. And I feel I'm fascinated to hear what Sarah is going to be talking about this afternoon. So during Sarah's fellowship, she was based at the University of Pennsylvania, working with some of the leading researchers and policymakers in the US on payment reform. And Sarah's experience over the last 12 months as part of that Harkness Fellowship has provided a great example of what can happen, I think, when universities and governments can collaborate. And that point brings us to the second reason for us being here today. And we're very pleased to have with us today Professor Michael Pervan, who's CEO of IHACPA, and Professor Ben Eggleston, who is Pro-Vice-Chancellor of Research. And Ben will join us. He's not here at the moment. He's on his way back from Westmead, I believe, but will join us this afternoon as well. And they're going to be signing a memorandum of understanding between the university and IHACPA, which is something that the university doesn't often do, and I believe something that IHACPA doesn't often do. So it's a pretty important occasion for both of us. So the focus of the Memorandum of Understanding is really to build a partnership between our two organisations, the University of Sydney and IHACPA, and really to develop, I guess, that analytical workforce and capacity building, and really facilitate research that is going to inform health and aged care policy and pricing. So we're at the Menzies, we're delighted to be the way, I guess, that this MoU is going to be operationalised, and we're very excited to be able to work on these really important financing and policy issues as we go forward. So without any further guff from me, let me introduce Sarah. Today's seminar presenter, as I said, is Dr. Sarah Neville, and she's the Director of Analytics at IHACPA. She's had a leading role in the development of the models that really underpin the price setting of public hospital activity, including the introduction of the safety and quality measures that were introduced in 2016 and 2020. As mentioned, Sarah's just returned from her 12-month Harkness Fellowship, which is fabulous. And she was able to pursue her interests in health funding systems, and particularly around innovative funding models. And so Sarah's presentation today is really around innovative funding reform, and specifically talking about bundled payments. So I'm very interested in hearing the presentation. So without any further ado, let me hand over to Sarah to begin her presentation. Thank you. Thanks, Sarah.
Hi, everyone. Just wanted to say thanks so much for the invitation to speak today. Really excited about the new MoU between IHACPA and the University of Sydney. I think it's something we've been really interested in pursuing at IHACPA for a long time, evidence-based research and getting it out into the peer-reviewed literature. And I think can I still call you new additions? I don't think so, but the introductions of Michael and Kees to IHACPA has really allowed research to become a key part of IHACPA's remit, which is super exciting for all of the staff at IHACPA. So a lot of you in the room haven't met me before in the physical room and the virtual room. So I'm going to introduce myself, and I really consider myself in 3 different roles. So first and foremost, I'm a statistician. I've got a PhD in mathematical statistics. So I'm a very analytical person and very quantitative, but I've also been in the health policy space for about 10 years. So with IHACPA in a variety of roles. And I consider myself to be a pretty hardcore public servant, and I probably will be one for life, and I wear that label very proudly. And then my final label that I put on myself now is as a researcher, particularly having just finished up 12 months in the US on a Harkness Fellowship. So today what I'm going to be talking to you about are innovative funding models, in particular bundled payments. But I'm going to start by giving you a little bit of insight into the Harkness Fellowship in healthcare policy and practice. Just so you get a bit of an idea of what the Harkness Fellowship is. And I think that's particularly important today because it's a really good example of a program that really fosters connections between government, universities, and also, in some cases, the private sector as well. So settle in, and we'll start with a little bit of a primer on the Harkness Fellowship. There we go. All right, so the Harkness Fellowship in Healthcare Policy and Practice is managed and governed by the Commonwealth Fund, which is a not-for-profit based out of New York, but also with a lot of people in DC in the States. And it provides a unique opportunity for individuals who are committed to advancing healthcare policy and practice to spend a year in the United States conducting internationally comparative research with mentorship from leading US experts. So the 22-23 cohort that I was a part of, and I was in the States from September 2022 to September this year, with a lot of support from my husband, who's here today, Tor. And basically there were 10 people from all around the world who are awarded the Harkness Fellowship every year. So generally there's 3 or 4 people from the UK, there's 2 French fellows, a Dutch fellow, a Norwegian fellow, and we all ended up in the States. All over the country, in fact. So traditionally, Harkness Fellows end up in the Northeast at places like Penn, where I was, or Harvard or Cornell. But over the years, I think particularly some of the POMs like the idea of the weather on the West Coast. So a lot of people ended up at Stanford in California. They had a much higher cost of living than we did in Philadelphia, but it all kind of evens out. So alongside a placement and a research project that's undertaken for the year, Harkness Fellows also engage in a series of leadership development activities, which are really, really wonderful. And in doing this, they gain an in-depth understanding of the US healthcare system and policy landscape and build a very robust network for cross-national exchange and collaboration. And then this year, so the cohort following mine, it's the first time there's been a fellow from Singapore. So that was quite a marked occasion. All right, so I didn't put too many photos in, but I had to put a couple in to give you a sense of the year. So you land in the US and you go to Harkness House, which is the Commonwealth Fund's headquarters on the Upper East Side in New York. And you go to an orientation seminar, which is an intensive 1 week, just very robust rundown of the US healthcare system. And you end up way more confused than you did at the beginning. But you leave that week with both a sense of how big the challenges are for the US and internationally, but also a real sense of how international collaboration can solve some of those challenges, or at least begin to solve some of them. So that's the 10 of us at the start of our Harkness Fellowship, bright and bushy-tailed. So you've got 4 UK fellows, a couple of French fellows, Dutch, Norwegian, and Jono at the front was my Kiwi counterpart. You also go to a 1-week Washington Policy Week, which is where you meet, a variety of politicians from both sides of the US political system, but also different private sector and policymaking individuals. There's opportunities to attend a variety of seminars throughout the year. One of the highlights was the Harvard Business School value-based healthcare course, which was really wonderful and taught by people who are sort of absolute, I want to say God, but gods of the value-based healthcare framework. We didn't see Michael Porter, and I didn't want to pay the $200,000 fee to watch him speak. But we got Elizabeth Teesberg, who was also an author of value-based healthcare, and Bob Kaplan. And that was really wonderful because he's really set the scene for a lot of activity-based costing framework. So that was really wonderful. There's also a California Innovation Week, and we got to go to the Taurus of Apple headquarters in Cupertino, and I absolutely had to take a screenshot of my invitation there. So that's Innovation Week. Just an absolutely bizarre and crazy facility. And then you round out the year back in New York City in the summertime to do your final reporting seminar. So that's the general Harkness year. Now I'm going to talk a little bit about my placement. So I was at the University of Pennsylvania in the Medical Ethics and Health Policy Division. Penn is one of the oldest universities in the US. I think it fights it out regularly. Cornell thinks they were the 4th, but Penn says they were the 4th. So there's all these like ridiculous rivalries. It had the first university medical school. And it's just a place of such rich history. It was founded by Benjamin Franklin in 1740, and every morning you sort of walk to work and walk past a brass statue of Benjamin Franklin, which was pretty inspiring. My 2 mentors for the year that I was incredibly lucky to be mentored by were these two men. So we've got Amal Navathe at the top, and then Ezekiel, but Zeke Emanuel. And you all might mention Zeke. He's a regular correspondent on CNN, and he was on Biden's COVID task force. And he famously wrote a piece that was then, the title was changed by an editor of the New York Times, and it was called Why I Want to Die at 75. So he's famously said that he will refuse any medical care after 75 because he prefers quality of life over quantity. So he's quite a character. 1 second. Yeah, so Zeke and Amal, they're both professors in health policy and medicine at the University of Pennsylvania, and they are co-directors of the Healthcare Transformation Institute, which is a really great example of 2 academics that are absolutely at the cutting edge of their field, but they're co-directors of a Healthcare Transformation Institute, which essentially is there to provide evidence-based policy advice for organizations like health insurance in the States, and to, really get down into the nitty-gritty of evidence-based policy, real-world problems. They do sit in an ivory tower of sorts, but I was really impressed by the fact that Amal and Zeke were really going out and engaging with the public and the private sector in the States, and really going down and solving those real-world problems, which was really great to see. All right, so that's a bit of a primer on how wonderful the Harkness Fellowship is. Applications are open every year. They actually closed a couple of days ago. So if you were thinking about it, you've missed the boat for this year, but keep your eye on it for next year if you are interested. I absolutely could not recommend it enough. So now probably for what you all came for, bundled payments. What makes them work and what did I learn in the States? Well, money talks, and what it's currently saying to healthcare providers, for example, primary care physicians, nurses, and surgeons, is perform as many treatments as possible, regardless of the outcome. It's this structure of healthcare payments, commonly known as fee-for-service, that has led to huge increases in healthcare spending globally without commensurate improvement in people's health. In fact, it often leads to harmful care. My work during the Harkness Fellowship was focused on what I consider to be one of the most promising alternatives to fee-for-service, called bundled payments, and I'll explain exactly what they are on the next slide. So what are they and how can they help fix the incentives behind how we pay for healthcare? Well, in my opinion, the US Centers for Medicare and Medicaid Services said it better than anyone else. A bundled payment is a payment structure in which different healthcare providers who are treating you for the same or related conditions are paid an overall sum for taking care of your condition, rather than being paid for each individual treatment, test, or procedure. In doing so, providers are rewarded for coordinating care, preventing complications and errors, and reducing unnecessary or duplicative tests and treatments. All right, so I've got a bit of a primer on healthcare payment on this slide. So people in the health payment space will be aware of these different ways that we can pay for healthcare. So we've got a spectrum. So we're moving from the left, which are very fragmented ways to pay for healthcare, and you've got less fragmented as you move to the right of the slide. But then you've also got a complexity continuum. So the more fragmented are also much less complex to implement, which is often why they're put in place. And we've got more complex as we move to the right. So on the left, we have fee-for-service, where basically there's a schedule of different services that can be provided and a price associated with each of them. Then as we move to the right, we've got diagnosis-related groups, which is the primary way that we pay for hospital care in Australia, where we pay for the inpatient part of care as, like, I like to think of it as a mini bundle. Then as we move along, we have bundled payments, which are the topic of the talk today, where we pay for an entire care pathway for a specific condition. And then all the way over to the right, we have capitation, which is where we pay for healthcare per person or per capita. Now, I kind of diss fee-for-service because it's very fragmented, but it's also very easy to implement. You have a schedule, you have a list of services and a list of prices, and you pay for them. But the risk gets quite complicated with fee-for-service. The majority of risk lies with the payer, because the provider of care knows that if they provide a service on the schedule, they will be paid for it. So they're not assuming any of the risk. As we move to the right, we get more and more risk lying with the provider of care. And with diagnosis-related groups and bundled payments, we have risk being shared between the payer and the provider to differing degrees. All right, so a little comparison of how the Australian healthcare system compares to the US. The States has almost double the proportion of GDP associated with healthcare. So healthcare costs absolutely out of control in the States. A lot of people said to me before I went to the States, why on earth are you going to America to learn about how you might fund healthcare efficiently. And I would sort of coyly say, well, it's a huge problem, so there's a huge amount of innovation over there. Lots of really great minds trying to solve the problem. And also, there's enough volume and there are enough markets to try new things. And there's a hell of a lot of innovation over there. Moving on to the universal healthcare question. Yes, in Australia, no in the States. That was one of the big, a big one of Obama's policies to try and get universal healthcare in. And a lot of sort of steps towards that in the States, but still not a lot of safety nets for historically disadvantaged populations. We're pretty highly regulated in Australia when it comes to healthcare in general, but also paying for healthcare. There is less regulation in the States when it comes to healthcare, but it really depends on who you ask as to whether the level of regulation is a good thing or a bad thing. If you talk to a venture capitalist in the Bay Area, they say there's way too much regulation. We can't do this, we can't do that. Whereas you'll talk to a policymaker in DC and they're looking for a lot more regulation in particular areas. Insurance, so majority public in Australia through Medicare with some, well, a significant amount of private interplay, but majority private in the United States. And the majority of that is provided through your employer. So when you watch shows like Seinfeld and they're asking if they have dental with their new job, that's like a really big consideration for people when they're considering employers. Like we might look at something like super here or the amount of leave you get, but medical insurance is a huge thing in the States as well. And there's some interesting history around that that I don't really have time to get into here, but maybe afterwards, if you're interested, we can talk about it. Another interesting difference between the US healthcare system and Australia is the access to specialist care. So specialist care here, you will all know, you go to your GP and you have to get a referral to go to a specialist. In the States, it's very different. And lots of things are different because of the Constitution and individual rights. So people can directly call a specialist, and if they're willing to pay for it, they can go to that specialist. The primary care physician doesn't have the same kind of gatekeeping job that it does in Australia. And people have very strong opinions on whether that's a good thing or a bad thing. And then finally, around value-based care and innovative funding models, look, there's been a lot of discussion around value-based care and innovative funding models in Australia. There's been discussion, there have been pilots undertaken, relatively small pilots, I would argue. Whereas in the United States, there's been large-scale national implementation of bundled payment programs since 2009. So they've been doing it. They've been evaluating it, monitoring it, and improving it for a long time, which is the primary reason why I wanted to go there and learn from what they've done before we try to kick something off in Australia so that we're not reinventing the wheel. So my major goal during the Harkness Fellowship was to understand the key factors behind designing and implementing effective bundled payment programs. And the major bundled payment program that I focused on is called the Bundled Payment for Care Improvement Advanced Program. Bit of a mouthful. I'll just call it BPCI. Essentially, it was a Medicare payment model. It covered 32 different clinical conditions. It was triggered when somebody had an inpatient stay at a hospital. And the bundle was defined as starting when they were admitted to hospital and and ending 90 days after discharge. And the key questions I was looking at were, how do you design? Well, what are the key considerations in designing, implementing, monitoring, and evaluating bundled payments that gives them the best chance of success? What are the key lessons learned so far in large-scale implementation of bundled payments in the US? And then, do bundled payments consistently target historically marginalized populations? So people of low socioeconomic status or different people from different racial backgrounds. And then finally, do bundled payments actually result in reduced spending and or better clinical outcomes? And what's the kind of quantum around that? So the three kind of key pieces of work that I undertook were bundled payments, what makes them work, which is a piece on design, implementation, monitoring, and evaluation of bundled payments. And this research was undertaken. It was a combination of sort of desktop and literature review to begin with, and then informal interviews with policymakers, academics, and private sector experts who really had on-the-ground experience with trying to get these bundled payment programs to work. And then I did two smaller pieces with the research group that I was working with at Penn, looking at what types of hospitals participated in bundled payment programs, because they are currently voluntary in the States. So a hospital can choose to opt in to these payment programs, usually if they foresee that it will be of net financial gain for them. And then finally, we were doing sort of a standard difference in difference evaluation of the BPCI Advanced program. So one of those pieces is currently under peer review. We're doing some small reviews and then it will be published. And then the other two are sort of pending. What's the word? They're pending. All right. Now, I think I'm coming up to time. Have I got a couple of... Yeah? All right. All right. So I'll just do a quick wrap up of some of the findings about what actually makes bundled payments work. Well, the first thing is that all parties, payers and providers, need to be educated and aligned on the aims of bundled payments. Seems like goes without saying, but it's absolutely necessary that everybody is on board and on the same page. Regarding the design of bundled payments, it's really important to have consistent rules and definitions regarding which conditions are covered, what is the triggering event, and what is included in and or excluded from the bundle. Part of this is deciding what conditions are amenable to bundled payments. And the research that I did sort of showed that surgical and procedural admissions tended to be more amenable to bundles than medical conditions like diabetes or people with a lot of different comorbidities. For this reason, surgical bundles might be a good starting point for a large-scale pilot program in Australia, and risk adjustment is absolutely key. Some important questions to ask when we're considering implementation is deciding who holds the funds. Quite a complex question, particularly in the Australian landscape, and whether payments will be made prospectively or retrospectively. Payments that are made prospectively tend to sort of set more of a benchmark. Retrospectively can get a little bit lost in the weeds, but often it's easier to start with retrospective payments than prospective ones. There's a need to determine how shared savings will be distributed, always pretty contentious. And ideally, you want to keep all players, so payers and providers, informed of progress through the bundle, through information and data sharing. It's really important to monitor outcomes and quality, otherwise underservicing is a real possibility. And then finally, mandatory participation is a really good thing in order to avoid selection issues. All right, so just a slide to summarise some implications for policy and practice in both the US and Australia. So I'll start with the US. Bundles have the potential to continue to improve outcomes and reduce costs, but they could be improved. So one thing that would be great would be to have mandatory participation of hospitals and physician groups. This is something that would have to be legislated, which would be reasonably contentious. Having some consistent bundle definitions in the States would be great. You have this situation where lots of private insurers are jumping on the value-based healthcare bandwagon and saying, we've got a bundle, yeah, but they're all completely different to each other. And that lack of consistency has been the source of some problems. Currently, the triggering events for bundles tend to be being admitted to hospital. And there's evidence to show that moving this trigger point further upstream into primary care or specialist care would be a really good thing, particularly for medical condition bundles. So ideally, if you have a medical issue, you would hope that it can be managed effectively through your GP and specialist to keep you out of hospital, which is one of the biggest sources of costs going up. So one solution to that would be centering design around how care actually happens in practice. And co-design is one of these really big buzzwords in the US at the moment, where you might want to co-design bundled payment programs with hospitals, clinicians, and also with patients and carers in mind. For Australia, under current Australian funding arrangements, bundled payments would probably have the best chance of working for conditions requiring surgical or procedural interventions. I'm not going to say an easy place to start because none of this is easy, but I think a reasonable place to start would be looking at a subset of surgical conditions and bundling the inpatient stay along with any rehabilitation that happens. That might be a really good starting point. So therefore, a reasonable implementation strategy could be piloting surgical and procedural bundles, and then hopefully once we show that they can work in improving outcomes and reducing costs, then moving on to medical bundles using diagnosis as the triggering event rather than having to go to hospital during primary or specialist care. Now, of course, this all would involve data linkage between primary care data and hospital data and, you know, everything that sort of surrounds the boundaries of that. So aged care is one, for example. So it's all so dependent on data, but that's why, you know, bundling inpatient stay and rehab for surgical conditions is probably a good place to start. Just a couple of leadership reflections to wrap up from my experience in the US. I was always really surprised by meeting sort of academic colleagues who also had private industry, not only experience, but they were still collaborating with people in the private industry and then also collaborating with government. It's not like, I feel like everyone I spoke to in the US had 3 jobs. Like Amal, who was my mentor, he's the vice chair of MedPAC. He's co-chair of the Healthcare Transformation Institute. He's a professor. He's on a board of a health insurer in California. And that sort of cross-sectional knowledge was really amazing. I think I learned in the US that non-authoritarian leadership is more empowering than traditional leadership methods. That was something that my 2 mentors really instilled in me. And I think it's really changed the way that I lead now that I'm back at IHACPA, hopefully for the better. And then also the importance of understanding and exploring other fields. I don't have any formal training in economics, and being around people who always ask the question when you were sort of jumping into a research project, you know, what's the incentive that we're trying to encourage here, and going back to first principles, that was really, really phenomenal. All right, so that is me. If there are any questions, I think Kees is going to MC.
Thank you. I'll come closer to the mic for all the people over there line. Thank you, Sarah. That's was great. What a great tour of your experience in the US. So yes, any questions? We have a few minutes available.
My name is Dolly. Thank you for sharing the experience. My question is, what was it that makes the surgical phase a good place to start? What is that trigger for? Because you said that in a few weeks.
Yeah.
So just I don't know if the microphones are picking up the question. So what I'll ask, what makes the surgical a good place to start for bundle payments?
Yeah. So I think there's a couple of elements to answering that question. I think the reason why, when we evaluated this BPCI program, the reason why we were seeing better outcomes and lower cost for surgical conditions rather than medical was because of the way that the payment was designed. Like, you had to go to hospital to trigger this bundled payment. So you have to go to hospital to get surgery. Well, I hope you do. So it was kind of, in a way, I think the way it was designed was more well suited to surgical payments. To surgical conditions. When you look at that definition of a bundle for medical conditions, you're kind of getting a much higher risk group of patients, because if they have a medical condition and they end up in hospital for it, they've already gotten to a stage where they're so unwell that they need to be hospitalized. So you're sort of getting quite a high risk group of patients where their costs and their outcomes, it's harder to get better outcomes for them, and it's also harder to kind of reel in the costs for those sorts of patients. So why would surgical be a good place to start for Australia? I think that's the majority of that is a data issue. So we currently aren't able to, effectively match primary care and hospital data. We are able to match inpatient data with a subacute state like rehabilitation. So it's a bit of a practical issue as well.
Thank you. Whilst the technology is being sorted, because we do have some online questions. One more. Sorry, Richard, and then Julie. Richard. Oh yes, microphone. Yes, you do. Yeah, that would be great.
Yeah, sure. Multitasking's not working.
Thank you. You made a very quick comment, I think talking about surgical bundles, that risk adjustment is essential. I would agree absolutely. But would you like to say something about how they're approaching risk adjustment in working up bundles? Thank you.
Sure. And that was a very big quip across risk adjustment, which is actually like an entire research field in its own right. But look, for the bundled payments for care improvement program, the risk adjustment is DRG based. So that's the way it's currently done. There are questions around inherent risk that isn't necessarily able to be measured in the data, which is always a risk. But it's a very hot issue at the moment that people are trying to solve. So I certainly don't have the answer, but I think particularly with bundled payments where the hospital stay is the trigger, DRG is a great place to start, seeing how well that works in terms of risk adjustment, and then using whatever else we have in the data handy, whether that's Indigenous status, whether that's remoteness. A lot of the adjustments that we already have in the national efficient price, I'd be testing whether they were also affecting or would need to be included in a risk adjustment model for a bundled payment.
I might just go for a question online because otherwise the phone will die on me and I'll have to ask Di to open it up again. And I will come back to the floor. So Sarah, given the restriction on what private health insurance can pay for inpatient hospital substitute and avoidance, how would bundled care work for medical conditions given the majority of care delivered after a hospital admission within 90 days would be in the outpatient setting for which a benefit cannot be paid?
Yeah, that's really interesting. And look, my research did not focus on the interplay between public and private, which would be a huge consideration in the Australian setting. So I'm not going to pretend to be an expert on that in any capacity. I think a great place to start. Oh, I love hearing my own voice. I think a great place to start would be, let's get it working in the public sector. And then, it's all about trying to get cooperation between the public sector and the private sector, being really clear with the patient journey. We actually tried to design a bundled price for maternity care back in 2018 at IHACPA. We did some really great work around that. But then we had roadblocks that included shared care arrangements, for example, particularly in Victoria, where, we just couldn't sort of untangle what was being provided, even by hospital providers versus GPs, let alone trying to then incorporate the private sector. So unfortunately, I don't have an answer for that one, but it's a really great question, and these are the things we have to be thinking about to try and move towards it.
Right. Yeah. Go to this gentleman there.
Hey, Sarah. Thanks so much for that. I think sidestepping the interplay between public and private, if we look at just private, where we use all those funding models you referred to, except probably capitation, but I think bundles are underutilized. Could you speak a little more about sharing the rewards of savings, and just thinking from a private hospital's perspective, if we want to take bundling models to insurers and incentivize them to engage meaningfully in those discussions, did you come across any examples of how that sort of plays out and what we could sell to them? Here's how we envision it working.
Yeah, so what happens a lot of the time is kind of, in order to kind of get providers to even consider entering into a bundled payment paradigm, you use risk to your advantage to start with. So, I mean, it would all be contract-based and you have to have like really watertight contracting. But if you were really just looking to get bundled payments off the ground, you would just have a contract that said it's only upside risk for you if you enter into this bundled payment program. You can only win. You can only have like a zero-sum game or win the first year of trying to implement these bundled payment programs. And then over a number of years, you could move to having upside and downside risk. Yeah, but look, it's just a situation where the devil is absolutely in the detail, and you have to be really, really confident that the contracts are reflecting the specifications of your bundled payment model, including how any upside or downside risk is going to affect both the payer and the provider.
And last, oh, the person with the microphone, Sean.
Thanks. I want to take a bit of a slide and move a little bit away from bundle payments and take advantage of for 12 months. And before you left, a number of your colleagues have said, why would you go there? Because that's where all the problems are. Now that you've been there for 12 months,
Well, I'm just mindful that I'm being recorded. No. I think a comment that I made after the Californian Innovation Week, and something that I think it's not just the problem in the US. I think it's kind of international, but it's very magnified in the US, is that it's not really a healthcare system. It's a sickness business. So it's a business over there. It's a business here in the private sector. And it's all about treating the sickness. Yes, being able to do that efficiently and effectively, but also making a profit. And it's not about moving towards preventative care so people don't end up in hospital. So, and that's because a lot of the payments are fee for service. And like I said at the beginning, money talks. If I'm a doctor, the doctors are just using the system that is there for them to use. So the more you do, the more you get paid. And it's the same here. So I think until we move to a system where payments are based on the outcomes for the patient, and instead on how much volume a provider can deliver, that's not going to change. And I think we've done a huge amount of talking about value-based healthcare and not a lot of doing. We've done some really good pilots, but we haven't tried to have this systemic change across the entire system. And I think that systemic change is going to have to come from something like the next National Health Reform Agreement. It has to be the new way of operating. It rather than just being a nice little research project on the side and a pilot, and we've shown these things can work on a small scale. It has to be the new normal. So I don't think that problem is unique to the US. I just think it's magnified over there because of the fact that it's private and the fact that it's market-based, and the fact that there's so much volume over there.
Okay. Yes, great. Thank you for keeping time, Di. So yes, I know there are other questions in the room, and so I hope we can move those in when we're having drinks. So thank you, Sarah. That's fantastic. So great insights. So now my pleasure to introduce my boss. By the way, I'm Kees van Gool. I work for IHACPA and I work for Menzies. So yeah. So introduce Michael. Michael spent over 20 years, has over 25 years experience in health and human service systems in Australia, and he has held positions in the Tasmanian health systems. He was secretary for 6 years and was Health Ministers Advisory Council and has chaired mental health and clinical principal committees of the council. And he's been a member of the IHACPA Council for over 10 years. A few words about the MoU.
Thank you so much, Kees. You didn't mention the fact that I used to drive a cab and paid my way through uni throwing people, including a former Attorney General of Australia, out of the University Tavern in WA. But that's all by the by. Since I am a guest in someone else's home, I would also like to acknowledge the traditional owners of the lands that we're in, the Gadigal people of the Eora Nation, and recognise their continuing connection to land, sky, waters and culture. In particular, I'd like to extend that acknowledgement and respect to the Aboriginal and Torres Strait Islander people who I know are joining us in this discussion today. I'd especially like to thank the university for hosting us on this very momentous day as we sign the Memorandum of Understanding between IHACPA and the University of Sydney. And thank you, Sarah, for that wonderfully engaging seminar. I've heard Sarah speak a couple of times now, And it's always an occasion that triggers a wealth of questions that go straight to the heart of what we're here to do. And it's true, there are a number of differences between us and the United States, but notwithstanding the differences, we have a lot more in common. Healthcare is still healthcare, disease is still disease, human behaviour is still the same. And so with the research and academic engines at Penn, at Harvard, at Cornell, at many other places across the United States, what they have for us is a Alibaba's cave of information analysis and tools that we can actually use and apply here if we're smart enough to do that. Once again, hence the reason why we're having this MoU. In particular, I was really glad and reflecting on the presentation we've just had, that the Harkness Fellowship gave Sarah the opportunity to experience the way that academics, policymakers, insurers, broader stakeholders work together in the United States to bring the best available evidence to the policy table. The two supervisors who hold multiple roles. I've had a similar experience with my mentor at a university in Massachusetts. And apart from the multiple roles they hold, the other thing that you immediately learn about them is their humility. So you'll meet a professor like that and they'll just hand you a business card that has, in my case, Don Berwick, MD. He doesn't point out that he's also the chair of the IHI and 400 other things. They are approachable, they want to engage and they want to educate. And that's something that we're all very, very keen on doing. I'm particularly glad that Sarah had the same experience as me. And we're incredibly fortunate that she came back to us. In fact, more than fortunate, we're also somewhat relieved. And to have her back at IHACPA and to bring all that experience and all those learnings with her. I think all of us here today, and certainly the questions so far are on the money, understand the challenges of bringing the best available evidence to the policy table. As Kees pointed out, before I joined IHACPA, I had a number of roles as Secretary of the Department of Health and Human Services in Tas, and for a few years there was Chair of the Australian Health Ministers Advisory Council. So for around a decade, I was lucky enough to be in those rooms, in hotels, in various places, and at the table to listen and be part of discussions around national health reform. As you would expect in a federal system, those discussions are never quiet and they're always pretty lively. Everyone thinks that they've got a solution, they just need money to implement it. But what was agreed and what was recognised 12 years ago was the importance of activity-based funding as a first step, particularly for hospitals, but also recognised at the same time that ABF isn't a solution for all of the problems and challenges that are confronting our health systems. The problem was not so much that ABF wasn't the answer to everything, it was also the way that we implemented it didn't make it a better solution than it could have been. As Sarah's already pointed out, the way we implemented ABF, it rewards volume without necessarily rewarding value. IHACPA has already made an important contribution towards that journey to value-based healthcare through introducing financial penalties for sentinel events, hospital-acquired complications, and avoidable hospital readmissions. But there, as you know, are growing calls for Australia to take the next steps in funding reform. And while you always get enthusiastic nods around the table in any of those discussions, it's not always clear what we should replace it with or even augment activity-based funding with. That's not really surprising. There's a growing recognition globally. There isn't a magic funding or financing solution. Bundles or bundling is certainly part of it, but there's nothing that we could just pick off a shelf and say, we'll implement that here, that will work. More importantly, funding systems alone don't bring around the sort of reform that we're needing to respond to the very quickly evolving needs of the population that have changed greatly since our health services and health systems came into being. Putting it bluntly, I think the question came up earlier, what was the problem? The problem is that we have a health system that was largely designed around treatment of infection and illness, and we now have a population which increasingly have multiple chronic conditions, have increasing frailty and are more and more complex. So we have a mismatch between the systems we've got to care and treat and the people who are needing those services. There's quite a journey to go in terms of redesigning our service delivery system and building a new funding mechanism to support the transition to and delivering of new ways of providing care to meet those changing needs for our population. Which brings me to why I'm so excited about this MoU between IHACPA and the university, the first of its kind for IHACPA. And given that there's only one of us, it's the first of its kind for Australia. I strongly believe this partnership marks the beginning of an incredibly important collaboration between our authority and the Menzies Centre for Health Policy and Economics. IHACPA's expertise in providing world-class analysis on healthcare costs and prices, combined with the Menzies Centre's record for delivering impactful research, will expand opportunities for multidisciplinary health policy and research. Our partnership will build Australia's capacity to apply evidence to improve our health system as a whole. It'll also offer new professional and learning opportunities. IHACPA has around 100 staff, and we're an incredibly technical agency with high levels of expertise in data science, service classifications, costing, data, and policy. Our remit, as you've heard, since 2011, has been to determine the efficient price for public hospital services, developing classification systems and setting standards for the data that underpin both costing and activity. As further endorsement of our agency, as well as the role of data-driven pricing in our care economy, IHACPA's remit was recently expanded to include aged care. We delivered our first residential aged care pricing advice to the Australian Minister for Health and Aged Care earlier this year. This advice now forms the basis of the Australian Government's funding contribution to the care of people in residential aged care. As with hospital care, our advice on residential aged care will now move into an annual cycle that includes consideration of new evidence and policy, such that the annual advice reflects changes in the costs of care. IHACPA has also been asked to provide advice to the Minister for pricing of services that are part of the Support at Home program. Now, I have not deliberately done the maths because I'm trying to manage my anxiety levels, but between hospital care, residential and supported home care, you're talking about 100 people and some very, very clever analysts and people like Sarah and Kees pricing around $40 to $50 billion of services to the Australian people annually. It's clear that the work of the agency is only expanding. New sectors, new and revised classifications, more data, and more analysis only point to more work. In fact, a Commonwealth colleague recently, very disturbingly, described us as being very sexy to government right now. More work points to the need to make sure that we're not only looking at our current expertise, but we're developing the next generation of technical experts and leaders in our field. And from my position, we're developing for the entire health system and aged care system and whatever else government gives us as well. In this regard, the MoU has an important contribution to make. It reflects a firm undertaking by IHACPA and the University of Sydney to expand staff recruitment and development opportunities. As part of the MoU's vision, we're enthusiastic to work with the Menzies Centre to develop a PhD program and start working on topics of research that are important to the future of Australia's care funding arrangements. At the same time, we're generating skills in relevant fields like data science, classifications, health economics and policy, as well as familiarity with our data holdings. So I'm incredibly proud to be signing this MoU today for IHACPA. And before stepping down, I'd just like to give a quick word of thanks to those who've made today's MoU possible. Andrew Wilson, who unfortunately isn't here this afternoon. Kirsten, straight in front of me. Kirsten Howard and Di Freeman at the Menzies Centre, members from the Sydney University Research Office, Olga Liavis and Dr. Sarah Neville from IHACPA. I'd also like to thank Professor Kees van Gool, who is Executive Director of Pricing and Analytics at IHACPA and Professor of Health Policy and Systems at the Menzies Centre, tolerates my endless questions and puzzles and thought bubbles, and who was the bridge who helped this MoU happen. Through this alliance, we hope to continue to develop our strong relationship with the Menzies Centre, working collaboratively on future research projects, building capability for analysis and evidence gathering, and building the workforce we need to support the evolution of our health and social care systems. Thank you all very much.
Thanks, Michael. That's great. It's now my great pleasure to introduce Professor Benjamin Eggleston. Benjamin Eggleston is a professor of physics at the University of Sydney and currently serves as our Pro-Vice Chancellor of Research. He's co-director of the New South Wales Smart Sensing Network and was a director of the University of Sydney Nano Institute, which I was mentioning to Kees was directly outside my office when I was in the Edward Ford building from 2018 to 2022, as well as the founding director of QDOS, the ARC Centre for Excellence in Ultra-High Bandwidth Devices for Optical Systems from 2003 to 2017. And my apologies if I'm stumbling over that. As a health economist, they're words I'm not entirely familiar with. He's a fellow of the Optical Society of America, IEEE Photonics SPIE, the Australian Academy of Technological Sciences and Engineering, and the Australian Academy of Sciences. And Benjamin will be signing on behalf of the University of Sydney today, and I would like to hand over to him for a few words as well. Thank you.
And there'll be a quiz at the end of the session to remember that that brief summary. Great to be here, and really impressive work that you're doing. I had a chance to catch up with Kees earlier today and to get a rundown on this very exciting MoU. So really exciting conversation, really timely conversation just to sit in the room and listen to the issues that you're grappling with. So you've already heard a little bit about me, but just to expand a little bit in terms of my credentials. PVC researcher, I report to the Deputy Vice Chancellor, and my remit is research operations. So I support the university's grants, contracts, integrity, ethics, clinical trials, governance. Lots of moving parts. Was spent this morning out at Westmead, meeting with the LHD and the Westmead precinct leaders. So very well attuned to the issues that are important in contemporary health. As Sydney Nano Director, one of our major initiatives was in nanomedicine. And so it turns out nanotechnology is these days mostly health and medical research. And as the co-director of the New South Wales Smart Sensing Network, a lot of engagement in healthcare and medtech, where sensors are very much providing that digital data that drives health benefits. So those are my credentials, but I'm really here to talk about this exciting relationship. So thank you, Michael, for your fantastic remarks and your leadership in establishing the MoU between our two organisations, the Independent Health and Aged Care Pricing Authority. It's a great acronym. And the Menzies Centre for Health Policy and Economics at the University of Sydney. It's a very well-known centre with some very distinguished colleagues. So we're really thrilled to sign this document and commit to working together on some of the biggest challenges facing our health and aged care systems. Now, it is often said that the test of a great society is how it treats its most vulnerable, and reflecting on the conversation we had before and the contrast between our society and maybe other societies around the world. In a rich country like Australia, when a person is struck by ill health or needs support in their old age, we all expect a system that delivers high quality care that is accessible to everyone. At the same time, we need to ensure that our system is sustainable so that there are enough resources for our care workforce to do their job effectively and efficiently. This is where the Independent Health and Aged Care Pricing Authority plays such a vital role, a crucial role in our health and now our aged care system. And it is why there are some very important opportunities that will arise out of this MoU, which we've just heard about from Michael. They're linking this to the University of Sydney strategic plan, which the Vice-Chancellor rolled out about a year and a half ago, and it's a 10-year plan. It's the 2032 strategy, indeed, that talks about the University of Sydney wanting to foster a culture where our students and academics can excel, engage, and have impact. And in particular, we talk about research, outstanding research that addresses the greatest challenges for the common good. And I think that language speaks to what is at play in this conversation and in this relationship. We want to achieve this by building partnerships with organisations such as IHACPA, is that okay? That are at the centre of policy. Under the MoU, we look forward to working with IHACPA to establish programs that will build both our organisation's capacity to develop the next generation of analysts and research leaders, as well as collaborate on research that delivers evidence for better health and aged care policy. Now, it is my pleasure, it says it's my pleasure now to invite you to join me for light refreshments, and thank you for your attendance, but we might also have the quick signing. So, but anyway, great to be here, great to meet you, and I look forward to having a chat with you outside. Thank you very much.
So thank you everyone for your attendance. Thank you, Sarah. Thank you, Michael. Thank you, Ben. I'd like to ask you both to have a seat and for the ceremonial signing of the document, and Kees is going to take some photos as well, I believe. So, and after the signing, we'd like to invite everyone to join us for some drinks in the foyer. Thank you.